It can support I'm not sure.
I think we don't need the live streaming right now for the introduction and SEO. After that,
It's already there.
it's already there. Oh, it is recording.
Yeah, can we mute this?
You can mute, right? Yeah.
Okay, so it's all now.
Good evening, everyone. Thank you for coming to the healthcare analytics, the workshop series number 1. How many of you, let me take the survey, how many of you have came here before? Will you raise your hand? Obviously, And so I assume that those that did not raise your hand are newcomers. So let me introduce myself. My name is Christine Lai, and I work at Vanderbilt University Medical Center. I'm the principal statistician and health economist at VUMC, which stands for the whole University Medical Center. This is a group. I'm one of the organizers. In our team, we have Claire, and we have another couple of people that couldn't come in today. Check our meetup website, and we all have our organizers' information there. If you have any questions, check on that. First of all, this is like come at you, go at you. It is no commitment, no obligation. And at the very beginning, it's a group. It's a group of me and a professor from the university side, and then a couple of my two friends. They are all in the healthcare professionals. And we hang out, we talk, and we meet every other week. And then later we find out that we would like to continue this meeting because I think we want to contribute to the profession. We really love our profession as a healthcare analytics person. So we love to connect people together. We don't collect fees, but we do go out to corporations to ask for sponsors. And so there are a couple of corporations that they are very supportive. The very first one that you can see is here, the National Technical Council. They provide this conference room for us free. Yeah. So which is very helpful to us because we don't have any money. We don't have any budget, we don't have endowment, whatever. Okay? So we just chip in our time. And back then we met at university at the medical center's conference room. I have the support of our chief, and he was very supportive. And then we find out that well, maybe we should change some places too, because people coming from different sides of the town. And we even had a meeting at for a whole year at health rates back in Tuesday, which we consider some consider it too far. So we try to change venue, but this seems so far so good. So if you have any venue that you want to suggest, or any places that you can offer, or your own company, if you say, hey, Christine, actually I would like to host one of our workshop or one of our meetings at our company. Talk to me or talk to Chad or talk to any of the organizers. So we really appreciate that you can also engage in the planning process. And first of all, say hi to your neighbor. Do you know that? So this is also a good opportunity for you to connect with people in the field, right? Yeah. Exchange your business card. Yeah. And I don't have business card. It's almost sad. I'm like, almost like
the whole week occurs. So it's like, if you want to condense it, yeah.
And if you really, really like your neighbor, after the workshop, you still can hang out with him or her, right? And go have a drink or have a coffee. Yeah. So, besides, we also have an announcement. Our sponsor, one of our sponsors, is SEO, the company that specialized in. I think that they are on the news recently, like the OPO, like predictive model, the predictive modeling. So let me get Jack, who works at SEO, and also get SEO as one of our sponsors. Very, very thank you for SEO for their sponsor for our drink, food, and also all the accessories. So Jack, can you?
Yeah, I'm Chad Yu. I'm one of the organizers of this meetup. Currently, I'm a senior research data scientist at Axial Healthcare. Yeah, if you know Axial Healthcare, yeah, you know me, right? So if you don't know, Axial Healthcare is a healthcare technology company focused on pain and opioid medicine. We work with all kinds of healthcare insurers. Yeah, to improve the patients with pain and opioid use disorders, yeah, to improve their outcome. So currently we have some openings in the analytics roles and also in engineer side. So if you are really interested, check out our website. If you are interested in any of the new jobs, yeah, let me know. I'll refer you to our HR. Thank you.
Again, thank you very much for SEOs that sponsor us for all the good food and drink. So let's start today's workshop. And first of all, again, my name is Christine Lai, and I work for Vanderbilt University Medical Center. The principal statistician and health economist are there. And again, the acknowledgement is really, really appreciate the National Tech Council for the conference room. And also thank you to SEOs and also among other sponsors for food and drink and accessories. So you don't have to worry, okay? So we don't collect any dues or whatever. And first of all, this is what we call the title of the workshop is Healthcare Data Scientist Workshop. So maybe you all know what is a data scientist, right? So can anyone tell me what is a data scientist? Maybe you are already one of them, right? So I Google it, I try to find it exact definition, but of course there are lots of definition. And so a data scientist is a person employed to analyze and interpret complex digital data such as the usage statistic of a website, especially in order to assist a business in its decision making. Do you think it's pretty correct? And then I go to Gartner IT website and try to find the definition there. And according to it, it says the data scientist role is critical for organizations looking to extract insight from information assets for big data initiatives and requires a broad combination of skills that may be fulfilled better as a team. So there's a whole paragraph talking about what that scientist is. Do you agree? So there's a slightly different between the first and the second, right? And just like the first, it didn't talk about big data, but the second one kind of emphasized on big data. So I go to my favorite software company, SAS, and then try to find out the definition there. According to them, data scientists are a new breed of analytic data experts who have the technical skills to solve complex problems and the curiosity, do you have it? And the curiosity to explore what problem needs to be solved. This is according to SAS, that is data scientist. And according to Harvard Business School, their Harvard Business Review, according to them, data scientist is the sexiest job in the 21st century. I don't know whether it is sexiest or not, but I think it's just a job, right? So a data scientist is someone who creates programming code, and combines it with statistical knowledge to create insight on business data, which is a much, much simpler definition when you compare the previous three. So if you really want to know the paper, why according to Harvard Business School, they call it data scientist is the sexiest job. Do you have the sexiest job yourself? Do you think so? Yeah. So, but according to this, I think more or less like you can find one of the versions that fits yourself or fits your definition of data scientist. Okay, but to me, healthcare, okay, if you apply, if you're a data scientist and you're working in the healthcare industry, this is pretty much is the arena you are in. If you can see in the center is the patient, okay, and then you have you go to hospital. I mean, not you. I mean the guy goes to hospital, and then you sometimes you go to clinic to have your annual check, and then you doctor prescribes some lab, and then you have to take some let's say medicine. The pharmacist, you have to visit the pharmacist, and then if you are over 65 years old, and then you can qualify for Medicare. That is the Medicare CMS there, and then according to the healthcare arena, you also need to know what is the public health policy as well. And of course, if you are still working, you have your medical insurance, which is the payers. Is your company have Cigna, Blue Cross Blue Shield, or Aetna? So every year you have in the open enrollment, right? It's a habit. Then you have to choose like which plan you want to. So possibly everyone here have gone through that kind of process, and it's coming soon in October, right? Or some even in November that you have to do the open enrollment. So this pretty much tell us all the parties involved in healthcare. Okay? We have the provider, and of course, not only hospital here. Probably there is one missing when we talk about hospital. It also include those not only the hospital, but also like aftercare, like the home health agency. It includes skilled nursing facility. It also includes long-term care hospital. So when we have the hospital there, doesn't mean that just the hospital. It's just like a facility, okay, that people can get their medical care. Which company in each area, which arena, which section that you're working in right now? How many of you work in a hospital? You raise your hand. How many of you work in for pharmacy or your work related to pharmacies? Like opioid, right? And how many is working in the government, like 10Care or the CMS or VA hospital? Yeah, so it is related to the government. Yeah, and how many of you like working at just like a provider, or how many of you working in the payer like a Cigna, medical insurance company, Blue Cross Blue Shield? Any of you? So anyway, yeah, you were. So, but all of these, each of this circle needs data scientists. Okay, they need data, and that's why I think makes Harvard Business School thinks that data scientist is sexiest, because you name it, each area, okay, that you need data scientists. So that's why there's a big demand for data scientists right now. And think about yourself. Okay? Think about yourself. What I have advised for people is when you think about you are in the healthcare industry, you think about your position, just like you buy a house or do a business, location, location, location. But as a career, you think about your position. Because the first position is your previous experience. Where did you come from? Are you coming from already healthcare related? It's not hospital, but healthcare related, like those consulting company or medical supplies company. So it is related. What kinds of experience you have that makes you have an edge, have an advantage to enter the healthcare industry? Your current role. What are you doing now? Are you satisfied? Is it you have the curiosity? Remember that word, curiosity, to do more, to know more, and in terms of data. The position. What do you want to be in the future? You want to be tomorrow, I want to be a medical doctor. That's good too, right? Or whatever. So think about like this three. What did you have that helped you today? And what are you doing today? And what do you want to be? And so hopefully this workshop series in healthcare data scientists can help you to move from your current role to your future role that you want to be. Hopefully we can help you to do that.
Can I ask a question?
Yes.
I'm thinking of the difference between like a clinical researcher and healthcare data scientist. I guess I wasn't familiar with clinical research. But it sounds like the healthcare scientist is coming from our business financial. So how do you merge, or how do you marry, or how do you work together with the researchers who are coming from a clinical, outcomes? Because healthcare, I know, is data driven on money, but it also needs to be worked on, what's the best care for the outcome of the patient too.
Good question. I like that because that's what I'm doing right now. My current role is doing it like, Phyllis' question is, let me reword it, yeah. Her question is like, data scientists, and according to her understanding, is to deal with a lot of financial data, how to cut the cost, how to have the revenue, and how to savings, and how to reduce the utilization, right? And how to cut people not going to hospital so often, right? But at the same time, the clinical side, like the provider, like a doctor and the nurses, what their focus is on the patient well-being, like the safety. And the patients, whether, they need the drugs, they do need the drugs, right? Even though the drugs are very expensive, right? They do need the prescription. And so is there like a balance between the cost and the quality? And looks like that if you want a higher quality, maybe you have to pay a higher cost. And so in terms of the data scientist, is it like a conflicting role, right? Right.
Well, you
how do you blend that together? So recently, for example, about 4 or 5 years, I have been working on like the CMS, and recently they have the bundle payment. Okay, in the bundle payment and also the readmission reduction program. They want the reduction of hospitalization utilization. They don't want patients to go to hospital so often, okay? Because some are unnecessary, yeah. But at the same time, some are needed. So you have to strike a balance between utilization and quality, the well-being. So according to CMS, it calls value. So they changed the payment formula to just for quantity, number of utilization, to value. Value is quality divided by cost. So it is the definition of value is the trade balance between the cost and quality. So CMS launched a bunch of payment reform in order to achieve that end, to resolve the seemingly conflict. But I don't think it's a conflict. They are not mutually exclusive. They can be, you can have the best care at the same time, can be at the least cost together. That's my belief. I think we can do that. Yeah, as a whole, as a nation. Yeah. So this workshop is very basic because this is the first in a series. I don't want to raise your expectation that, today we are going to do the logistic regression. We are going to do this system simultaneous equation estimation. No. We are not doing that. Yeah, right. We are not doing that. Yeah, even though sometimes I do it, but I'm not going to teach that today. Well, what we are trying to achieve today is very, very basic. First of all, if you are a data scientist, you better know your data, right? You better know your data. If you don't have the data, how can you be a data scientist? So the number one is you need to know your data. You need to know where to find it. You need to know what types of data it is. You need to know the limitation of your data. You need to know how to handle the qualification of the data. So very first is know your data, and then we'll go through. Okay, and also the second, because you're working, you work for your boss, and you provide your service to your client, maybe the CEO, or maybe the CFO, or maybe your director, or maybe a group of medical doctors. You know your clients, what they need. Okay, you don't provide anything that they don't need. It's a waste of the time. It's a waste of their time, even though it is a very fine piece of regression. But they don't need it. Okay, why produce it? So you need the need of your clients. Okay, what do they want? Okay, internal or external. If you're consulting, if you're a consulting company, then you need to know your external clients, what do they want. Of course, healthcare, right? The cornerstone of the whole arena is the patient. You need to know your patients. You need to know who they are, how old are they, and what condition they have, why they come up to the hospital, why they come back to the hospital the next 5 days, okay? Why they use opium, why they use so many and so in so short of a time. So you need to know your patient as well, because patient is the cornerstone of the whole arena. You need to know about what's happening. Who are they? Are they young? Are they old? Are they abuser? Are they like, where do they live? Okay. And then after you know these 3 no, okay, good. Roll up your sleeve. Leverage your skill. If you're a statistician, you know a lot about statistics. If you are an IT person, you know a lot of a database. If you are a programmer, you know you're very good at writing scripts. So leverage your skill. Think about position. Think about what do you have to offer. Okay? If you never take statistics class, then maybe you need to take one tomorrow. Okay? If you want to be a statistician, okay? If you want to do hypothesis testing, you cannot do a hypothesis testing without knowledge of statistics, right? So know your position, know what you already have, and know what you don't have, and then you go for the next step. Equip with your tools. Pick software. Pick your own software. Some use R. And how many are here? Let me take a survey. How many of you use R, the open source software? There. Okay. How many of you use my favorite tools? SAS, S-A-S.
Oh, that's tough.
Good. That's my favorite. How many of you use Python? Wow, that's a lot. Yeah. How many of you use just Excel? No, I don't want you to just. How many of you use the great Excel? Okay, Excel actually is very powerful. Okay, so sometimes, especially now, how many of you use the Power BI? The Power BI? Yeah, it is very, very cool. So I love it. Yeah, so think about what kinds of tools that you feel comfortable, that you have been using for years, or you have been learning it and you feel comfortable using it, you like it, stick with it, okay? And then just use it. Even though it's not the sexiest tools that, and then the whole team is using something else, and then you are the only one that use that tool. Don't worry about others, because the tool is you use it, it's not people use it, okay? Just stick with one that you feel comfortable. Capitalize your resources. What does that mean? Meaning that say hi to your neighbor. Okay. Hey, are you working on some projects that I don't know? Okay. Hey, I saw your project that you showed this very cool data. Where can I find it? Okay. Look for your network here. Make a call. Hey, Christine, I saw one time you showed this kind of data that is very cool, and we can use it as a benchmark. Where did you find it? Use the meetup. Okay, come to the conference, come to any of the meetup, especially those free, or especially those with food and drink, okay? And so go out to find your resources, go out to find your network, because 2 brain better than 1 brain, because people around you are usually very nice. They are willing to help you if you have a question for them, including me, okay? Just give me a call. And seize opportunity. Now is the opportunity to be a healthcare data scientist, because our whole economy, we have an aging population, And then people like are more health conscious. They go to annual check every 6 months. Okay, compared to people like maybe your grandma, your grandpa, they never go to annual check, right? But nowadays people go to annual check. So suddenly they have a little bit like fever. They go to the emergency room. So they learn about a lot of like healthcare services that they want to use. And so data scientists, this is the golden age to be a healthcare data scientist. Seize the opportunity, go for it. Okay. Number one, the free know your data. I'm not going to go through all this, but this is a list that you can go in if you want to find some data to work with, or you especially for all this, you want to know about benchmark. Number one, of course, your own data, your own hospital, your own company. If you work for a payer, let's say Cigna or Humana or Blue Cross Blue Shield, your claims data, okay? That is most valuable data that you want to learn. And then if you want to have some kinds of benchmark, outside, external, their government data, okay? Department of Health and Human Services, Bureau of Economic Analysis, Tennessee Department of Health, Tennessee Hospital Association, and all the other government agencies like QualityNet, Yale, ResDat, Research Data Assistance Center, ResDat. How many of you here heard about ResDat at University of Minnesota? Not many, huh? You do, right? How do you know it? Where do you get it?
So I'm still a PhD student. So for my research, we are getting Medicaid data from ResDat. So at the University of Minnesota, there are research assistants there who help us kind of acquire what we need.
Yeah. I have to thumbs up for the ResDat because I went there to take the training, the CMS training. They are so cool, yeah. And then if you visit their website, which I will show you in a minute, if you visit their website, they have everything, yeah. And then if you don't understand, you make a call to Fame and tell her, say, I need this data. So she'll help you. So ResDat is a very, very good source. I mean, this to me. Yeah. So these are all your resources. Yeah. And there are other academic and hospital ranking agency, of course, insurance company. If you go to United Health, you go to Cigna, sometimes they will have some kind of report. Of course, it may not be relevant to your company or your hospital or your provider group, but most of the time they will have a big picture. They have reports on big pictures that you can reference. Yeah. And
question, Christina.
yes.
Are there groups outside of the U.S. academic that are very significant? Other non-U.S. groups?
Non-U.S. group? Yes, I think there are two, like in Germany. Yeah, they are in Canada, Germany. Yeah, they. I think I never visit the site, but I heard there is one meeting before that. Ladies, she originated from Germany. They also there. Actually, we have one guest speaker talking about the healthcare in Germany. There is some like link that you can go there to check. Yeah. So if you are interested in that area, go to our meetup site. There is some past PowerPoint there.
Okay, true.
Yeah. So there might be some. I remember there's one talking about comparing the U.S. healthcare system with the Germany, and then and then they have some. Yeah. Remember? Yeah. We have that PowerPoint. At least I have. Yeah. So also note your type, your data types, okay? The sources and the type. Is it a patient encounter level? Is it a summary, aggregative statistic? Is it like you collect it firsthand, okay? Primary, like survey from the patient. Or secondary, a benchmark, a report, okay? And all the others like academic report or white papers, and then the government site. And sometimes if you go to the Federal Registry, they will have some reports there. According to their research, they find X and Y numbers, in certain areas. So these are your resources that you can reference. Yeah, this is like all the tools. Of course, this is just some tools. There are a long list, right? And as we already know, there's like our studio, So for those who use R, probably you're very familiar with this site, right? You can download R from this site if you don't have it. And bear with us if you are very, very savvy with R, because I think some of our members here, they may not know R, so I just introduce everything, okay? So this is the website that you can download R and also getting help here. And also there's documentation link as well. And how can I get it back? How can I get it? Huh?
Just close it.
Just close it?
Close the tab,
Yeah, close it.
Oh, okay.
the little X.
Okay. And then I never asked any of you use a Stacker here. And Stacker is another good software that you can use. I'm not sure whether you ever come across this. How many of you heard about, how many of you know Stacker? Yeah, is it good? Do you use it? Used to be? Yeah, why not now?
Can't handle like large business.
Oh, okay. Is there a limit? There's a limit there?
I used to when I was on undergrad, never used to.
Okay, yeah. So, but they have very, very cool, yeah, graph, and they have very cool statistical package, and you can call it out to do it. So, Stacker is another one that you might want to consider. And then, of course, Power BI that I mentioned. Yeah, Power BI that you also can have a free yeah, for those people who use Power BI, you already know. And for those who know, you can download it free as a free trial and see it. It is pretty powerful. Actually, it is Access and Excel combined. Yeah, right? Am I right? So my understanding is that. And actually, there is another meetup, Microsoft meetup in town. If you like, it is like you can go to the meetup site and check them out. And they also offer pizza. Yeah, but usually they meet at noon time. Yeah, 12 to 1. Yeah. And how many of you in your company or your teammate use Tableau? Here. Yeah. So, wow, there's a lot, right? To me, I think Tableau is like a video game for the executive people. Do you think so? To me, I think it's really like, yeah, try to get into, yeah. Right? So they have very fancy graphic stuff. Yeah, but according to me, okay, this is my only personal opinion, is you spend 99% of your time like setting up the data, and then you use that 1%, put it into Tableau. Right? So that's my personal, yeah. But it's cool because the executive people can like play video game. Yeah, and it's cool because they can change the color, they can change the shape, they can change whatever. And then of course my favorite, SAS. Okay, and again for SAS, if you want to learn SAS, you can download SAS. Also, it's a free trial, and they even have like health analytics. They have a lot of good white papers on healthcare analytics. Very, very cool, up to state of the art. Because think about what SAS originated for, clinical analysis. So, because most of the package there is for clinical. So it is like the most legitimate tools for healthcare analytics, according to me. But you may not agree. So different people have different take. But I really like healthcare analytics in SAS. Yeah, you can see See, they can even know. Do you have questions? One time I remember that I want to do some graph and I don't know how to do it, and I type it in. They said, "Oh, cool, grab this script, done." So that's my favorite. Yeah. So probably we don't need that now. Okay. Anyone have question for Seth? No. Okay. So let's do okay, let's do workshop number 1. Have you turned on your computer? Okay. You got a business issue. Okay. Your boss come to you, or your executive come to you, or your directors come to you and say, "Hey, Joe, I want to know how many patients that discharged in my hospital the last year." Okay, by MSDLG, hopefully you know what is MSDLG, which is the coding for, which is the reimbursement coding for CMS, and also most of the commercial payers will adopt it. And so the payment is according to the MSDLG, the diagnostic related group. And then the MS is like comorbidity or with complication. Yeah. So number 1, we want to know for the last year how many patients we discharged according by MSDLG, and is there any relationship between our hospital's volumes with next door? Okay, and is there any difference in charges and payments? Okay, let's say you got these 3 questions from your boss. So where did you get your data? Your own data, your in-house data, your own. Make a call to your IT people, your database people, and say, "Hey, I want this kind of data." Okay, your own data. If you don't have it, let's go to the CMS and take a look. Okay, and the file that you download. Anyone have question or trouble with downloading? If not, you can. If you haven't had the file yet, you can just download from here. You can copy from here to here. Okay. So you can either download as a CSV or download as an Excel, because it's not that big. Actually, it's not that big. Okay. How many rows? How many rows of record there?
197,000.
Yeah, it's not big. Yeah. So so it is the inpatient. Again, this is only hospital. Okay. If you work in a provider group, a clinic, the number is not there. It is only for in hospital. Okay. So know your data. Number 1. You need to know what that data comes from, what kinds of data it is. Okay? And use your tools. If you are Excel lover, just stick with your Excel. If you use SAS, use SAS. If you use R, use R. Okay? Have you done it? Number 1, 2, 3. First of all, you go back to your clients or your boss, say, "Hey, what exactly what you want? Okay? Would you tell me more specific?" So what your clients wants to know, always remember, it's not what you can do. "Oh, I can build you a logistic regression. I can build you a system or a simulation." No, it's not what you can do. It's your clients what they want to look at. So make sure, okay, don't mix them up. For example, like, okay, this is a simple report. How many discharges and total payments that our hospital had discharged in FY 2016. This FY financial year is the CMS financial year because according to our data by MSDLG, comparing to our competitors. Okay. So, have you done it? So I use Excel. Okay, this is simple, so you can just use Excel, right? You don't need that fancy $25,000 subscription software. Okay, and see whether this is what I built. First of all, you have this. So I use a VUMC, Vanderbilt University Medical Center, and our neighbor, St. Thomas. Okay, so try to compare. You can pick your own. Okay, you can pick your own hospital. You can pick your competitors, seemingly competitors, and to compare. Okay, and so what I built is here, and then in the Excel, when you get your data. When you get your data here, this is the data I have, right? Does it look like what you have? Yeah, you have the provider, and then the city, and the state, and the zip code, and the total discharges, and then you have the average cover charges, you have the average total payment, the average medical payment. So this is all you have, okay? Look the same as what you have, okay? And then go there, you know the pivot table, just go and highlight the whole cells, and then insert pivot table. Excel is pretty cool. They have a pivot table, okay? So you can use the pivot table, and once you have the pivot table, it will look like this. It will look like this. And then, see, it will give you all the columns, all the fields in your file, and then you can pick what you want. You can pick like, okay, for example, at the very beginning, I want to look at just Tennessee. So I put in the filter, provider state, as Tennessee. Of course, you can pick like New York or DC there. So you can pick any state. And this is the DRG definition here. So it's a 3-digit. And then it will tell you what it is. And here's the provider ID here. For Vanderbilt is 440039. And for St. Thomas is 440133. And then the provider name. So you know what the numbers means. And then here you just like the total discharges and their total payment. Okay, so, and I sort, okay, of course you can also, if you click any, so you can sort it. Let's see. Right click it, then you can sort here. Okay, so this is in Excel, yes.
So when you normally start with a data set, would you start at Excel? Is this the first thing you do?
No.
Okay.
No. Depends what my clients want.
Okay. So I'm just saying, if you don't know your data set, let's say you get a brand new data set, you're pulling from a new source. Like what's the first
My first step is to check what kinds of data it is, how big it is.
Right.
If it is very big, then probably you don't use Excel. But if it is like a couple million, yeah, because it will be slow. I'm not saying that Excel will do it, but it's slow. It will be slow. You won't use heavily, slow, right? And you use R, you use SAS. Okay, SAS is very quick, boom. Yeah. So it really depends on the tools that you are comfortable with. If you're comfortable with R, we will have script of R right away. Okay. Right. So is it okay with everyone with the Excel? Probably you already did it. You probably did it better than I did. Yeah. So here I have like the provider name here for my client. This is what I call the slicer. So you use slicer in Excel. Okay. In Excel, there's a slicer that allow your clients, or for example, I work for this medical doctor. He really like to do it himself. Yeah, he's smart, so he want to pick his own competitors. Okay, and so he will go there and pick it. Yeah, maybe he wants to pick Cleveland Clinic because he's a clinical person. And to me, I would like to just make sure St. Thomas, that's good enough for me. But he would like to see Duke. They would like to see Cleveland Clinic. Do you see what I mean? So it really depends on, then it enables your clients to pick whatever. This is the slicer. And then also you develop this framework, set up this framework. And so for him, he can do it. Okay, so let's move on to another one because I think this is not very exciting in Excel, right? Everybody knows how to do it.
And maybe you're going to do this, and I think the purpose of this is going to show us what tools to do. But I mean, if like you're the hospital administrator, you want to know these things. If you're really going to get the true data, that huge baseline of data has to be cleaned up.
Yes.
Because I mean, there are so many variables in that that you can't get a true analysis here.
Let us give a big applause to Sarah because she reminds us
one thing that I forgot to tell you. Number one, before you use your data, clean your data. Don't just use it, okay? Especially your own in-house data, okay? This, I forgot because why? Because this is CMS data. They're so clean. They're so clean. So there's nothing that I can do to clean it because they have more knowledge than I do. If I work in CMS, I will clean it. But as long as they put it into the public use file, they call it the PUF, it should be clean. So I don't have to worry about that because CMS is a trustworthy, right? It's a trustworthy organization. And so I trust it.
I think the government trusts it.
Yeah. So I don't even worry about it. But if you're in-house, if you got a file from your teammates, if you got a file from your finance co-worker, if you got a file from a nurse, you better clean it up for months to come. I remember one time I cleaned up one file that the nurse gave me. I spent like 2-3 months to clean up that Excel file, just that Excel file. So thank you very much, Phyllis, for reminding us that first, clean your data before you use it. The one that we didn't do tonight because CMS is my trustworthy data source, so I just don't even check it. But thank you very much that whenever you use your data, you got to check it. Random check.
Another question, should we assume in organizations like describing that there would be a data steward or someone in charge of data quality?
Yes, it's supposed. Yeah. Every organization have their own data governance custodians, and so it depends on your company. Do they have a gatekeeper? Yeah. And I'm not at any liberty to say about that. Okay. So, but if for me, whatever data that I come to my desk, I will like verify it, validate it, and due diligence. Yeah, before I even compile it. Before, yeah. So because there are some cases that you don't want to put it into the mean calculation because they are not valid.
Sure.
Yeah. So you would like spot something. Yeah. So since this is like CMS data, government data, so I assume that it's pretty okay. All right. So this is already there, and then there is one correlation. Remember your boss tells you to do what is your MSDLG volumes. Okay, you did it. And then also, is there any relationship between your business with next door business, which is the total discharge, the volumes? So this is the VOMC, number of discharges. And this is like St. Thomas Midtown, number of charges. Do you think there's a correlation there? So for that same MSDLG, if we have more volume in that, St. Thomas will also have more volume in that same MSDLG. Does it look like we have it? Eyeballing it? Sometimes my prescription is very high, so I don't trust my eyes. So I usually do a statistical analysis, just compile the correlation matrix. Okay, compile the correlation in Excel. You can call out the correlation. Okay, probably all of you knows how to do it. You go to your data. You go to your data analysis, and here, if you don't have the data analysis package, you have to add in. Go to your Excel advanced adds in and to pick that. And there is a list of statistical analysis that you can pick. You can pick the correlation, you can pick histogram, you can pick regression too. You can pick the t-test pair 2 samples for means. So there's a bunch of like statistical, of course, these are very simple, right? These are very basic, but sometimes it's good enough, depends on your clients, what your clients want. Maybe he just want the correlation. Done. This is good enough. Yeah. So you can remember again, it is under data analysis, and then you pick it. Okay, and then it will pop up a window interactive
manual for you to pick. And you can have this correlation is 0.59, which is positive. Okay? What is missing there? When you come to this point, it's 0.59. What is missing there? Is it significant or not? We don't know. Is it 0.59 high, low, medium? Right? You know that the direction is positive, meaning that if the volumes of discharges is high in one hospital, the other hospital also high as well. It's also, they go hands in hand. But is that significant or not? So unfortunately, in Excel, you do not have the p-value. Okay, I don't want to go too deep into what p-value is, but I don't want to draw your attention. So if you want to know what p-value, come back in spring, January. We'll talk more about just one workshop on statistics. How about that? But this is like just an overview, okay? And then you can, there is a way to get around that, even though correlation, it does not provide you p-value in Excel, but here, if you do the regression, it does provide you the p-value here, which is very significant. Okay? And then the R-square of a simple regression here already is your correlation. Okay? So in order to just run the correlation, you can run the simple regression. Remember, it has to be a simple regression, otherwise it doesn't work. Okay, and then you look at the p-value here, and this is your correlation. So there's a way to get around it. Yeah. Well, let's jump back to our R. Okay. So probably some of you want to look at the R report. Okay. So see if you are using R, do you have the same script as mine and doing the same thing? So I use the R Studio because it is very easy to use and more friendly, user-friendly. And so most of the people not only download R, but also download the R Studio. So this is like my workshop number 1. So I read in the data. First of all, I set up my work directory, and then I read in my CMS data here. And then I do some kinds of like checking on the file, or what are the names, what are the summary of it, okay? And then I pick my own favorite hospital, Vanderbilt and St. Thomas, and I want to compare them. So I kind of comparing them side by side. And then I do a correlation. And so let's run this and see if you like it. Did you run yours? Does it work? Yeah. So what I do is to compare the two hospitals, their total charges, and also the correlation.
What libraries are you using here?
The library I use is, let me see here.
Size HPs, right?
Yeah, the correlation I use is HMISC here. Yeah, because it can provide you with the p-value. Yeah, if you just use the R, it won't provide you the p-value. You want the p-value, so you need to download, install the package HMISC, and then call it out and do your own correlation. I think I did also prop too. Where is it? Yeah, I think I do the prop. Yeah, so. Yeah, I kind of plot the graph here. It looks weird because we have the two, what we call maybe potential outlier here, this one and this one, right? So that's why it make it like a little bit like curve. If you ignore this 2 point, then possibly it is just like a straight line here. It is positively related. Okay. So this is the R script that I did, a very, very simple, and then comparison between the Vanderbilt and St. Thomas total discharges volume. So probably this looks very familiar with you. You have to just do some a little bit like data manipulation, like take out a portion of the file and then take another portion and combine them back together. Yeah. So this is not very fancy stuff. This is very basic. Yeah. And then you can plot and take a look at how does it look like to get a feel. Okay. Doesn't mean that you buy it. Yeah. It's just like eyeballing it. Yeah. And my favorite SAS. See what SAS can do for us, okay, in terms of this task. Your boss tells you to do this task. And the SAS that I use, the SAS version that I use, is the Enterprise Guide. How many of you use Enterprise Guide? Do you use Enterprise Guide? Yeah, that is, at first I kind of hesitate to use it, but then the more I use it, the more I love it. This is pretty good. Yeah, so. So once you write the script, and you can just hit run, and then it will give you everything in one place. So again, you can see that you can write a SQL, you can prop import to get the file, and then you write a SQL to set up the database. Here you have. So this is like, again, this is like it automatically gives you the p-value here. And the correlation matrix is 0.59320. Okay. And I also did the payment as well. Okay. Looks like the payment is not very highly, it's not related at all. Yeah. And this is the top 10. This is the top 10 DLG. St. Thomas have the most. So it's 499 cases of major joint, and then 166 cases of the septicemia, etc., etc. Then this is the top. Okay. So you can see like what Excel can do, what R can do, and what SAS can do. So you have like 3 different kinds of tools. Or if you go to Stacker, Stacker probably can do the same thing as well. So to me, tool is not very important. The most important is know your data. You have to know your data, because no matter what tools you use, if you don't know your data, probably you don't have good analytics. Number 1, know your data. Number 1, know your data. Just know your data, period, okay? And tool is just tools. And if you don't know how to use it, you just type Google search. Then Google search can tell you, or you go to that website. If you don't know how to do correlation in R. Oh, this morning, actually this afternoon when I do the correlation, I said, hey, how come it doesn't pop up a p-value? So I checked the R website. Oh, okay, if you need a p-value, then you need to install this package. So I installed the package, MISC. Boom, done. So nowadays, learning tool is secondary. I'm not secondary. I mean, it's not that bothering me. What bothering me is, do you know your data? Okay. What kinds of data you have? Is it patient level? Okay. The reasons I talk about is, do you know what this means? Do you know what MSDLG means? Why it is so important that your CFO asks you to crunch out a list of the top 10 MSDLG volumes and payment. Why? Because CMS, the reimbursement, is paid by MSDLG. You see what I mean? So it depends. So This is mechanic, and it means nothing. But why your clients ask you to do carries meaning. Okay? Always trust your clients, because your clients, whenever they ask you to do something, they have their reasons to ask for it. Yeah. It's not what you can do. Always remember, you can do fancy stuff, you can do very beautiful report, but doesn't mean that that's the things that they want.
Christine,
Yeah.
question. I think what you said is really important. I like this very much. Some of your clients need those other questions. If you're managing people responsible for data, just wondering, how do you know if they know their data? How does someone know? Do you have a heuristic, like six things that will tell you if someone knows their data sets?
Yes, I come across a lot of questions to me. By what question people ask me, I can pretty much know how much they know. You know what I mean? If they said like,
let's say this MSDLG, okay.
let's say later state, okay? Maybe we can keep the patient one more day here, and charge more, get more money. If this is a Medicare patient, do you think you can do that? No. Because even the patients stay by a month, stay one more day, 2 more days, they're still by MSDLG.
Yeah.
Right? See, right, Jeff? You know that, right?
Yeah.
So if people, you see what I mean? That is the sense that in the healthcare, I think that is the most important is, do you know much about your field? Do you know much about your data?
Your utilization nurse is going to be after you do that.
Yeah, that's another issue. But then by asking questions, I'm not saying that people should not ask questions, but then you ask a sensible questions sometimes then, because they don't know. That's okay. If you don't know, you don't know. Yeah. Then you can tell them, oh, it won't work because if you want to stay. Yeah, we're still the same. Actually, we should reduce the length of stay instead of keeping they here more, because the more days they have, we still get paid the same for Medicare patients, right? Yeah. So it just depends on. Did I answer your questions?
Yes.
Like something like that. I have come across several questions about healthcare that I don't want to laugh. I'm just like, oh, okay. I'll tell you why that question doesn't make sense. Yeah, that kind of things. You know it. You know it. Yeah. For example, readmission rate. Oh, actually, I'm going to take that readmission. Good point. Okay, you did it. You did it. Okay. Did you check your data? Okay. After you did all this report, did you check your data before you send it to your clients? Okay. Does it make sense to you? Is this the 470? Is that your hospital's top discharge volume? Okay. Check with the nurse. They know better than you do. Okay. Even though we are CCS, but they know more than us. Yeah. Even though professionally we are CCS according to Harvard Business School, but you check with your doctor, you check with your nurses if you work in a hospital. Okay. Okay. The first round result, we did it. Okay. And then people said, oh, if you look at your top 10, okay, look at your top 10. Okay. Hey, heart failure 212291, MSDLG 292291 is heart failure. It's include in top 10, and it also include in CMS HRRP, which stands for Hospital Readmission Reduction Program. Have you heard about that? Have you heard about HRRP program? Okay, this is one of the payment reform, a very, very important policy in payment reform. Okay, and so your boss will say, oh, good job. Can you tell me what is our hospital readmission rate in heart failure? Where did you find it? Where did you find it? You find it here. Every year, CMS will announce in their website all the hospitals in the United States, what is their readmission rate in certain readmission reduction program, okay? And They also have the file for you. This is the payment adjustment non-stratified methodology. If you want to know, come to January, okay? I'll tell you about these whole things, okay? And how they calculate the payment adjustment, what they call the adjustment factors, okay? And this is another whole arena. This is what in our, at the very beginning of the PowerPoint, we have those arena, and there's one is the policy, government policy. This is one of them, yeah. And at the end, there is like these files. Hospital readmission reduction program supplemental data file. This is the data file that you can check all the hospitals' readmission rate, not only your hospital, but also other hospitals as well. Yes, questions?
So this is that why St. Thomas Community for license would get versus like on average different rates, like off by $1,000.
Yeah, yes, good point. Because I don't want to open the test because this is a very, very big area. So every year, CMS will calculate the readmission rate on several conditions: heart failure, AMI, total joint, and stroke. Right? And then they calculate your hospital how many is over the expected rate. And according to that, if you have too much over the national benchmark, then you will be reimbursed by this amount. Let's check. Okay, I have it here. Let me here. Okay, the first one is Vanderbilt, which is provider ID. This is St. Thomas. Okay. The FY 2018 readmission adjustment factor, 0.9988. For St. Thomas, is 1, meaning that if you submit your claim for $1, CMS will pay you $1. But for Vanderbilt, if you submit $1, you are only paid, Vanderbilt will be only paid by 0.9988. Well, it's small, right? It's just a 0.0012. But if you multiply millions and millions dollars,
The penny factor.
that is a lot of money. You see what I mean? So if it is 1, meaning that you don't have any penalty. Okay? Actually, it reflects the penalty. 1 factor is equal to 1, meaning no penalty. Any number lower than 1, meaning that, for example, like this, Vanderbilt is paying a penalty. That means how it is converted to dollar is converted into the reimbursement rate. So back to your observation that there's difference between the payment from the CMS. Did I answer your questions?
Yeah, so for all information, Vandy's 2% lower
Oh, it's not 2%, it's 0.001 like that. Anyway. Yes, yeah. So if you are the CFO or you are the financial person in US in America, you are not happy.
Yeah.
I'm not happy too. But anyway, this is true. But how does it convert? I mean, how this is calculated? It is based on this, based on this, based on this, based on this, and based on this. So there is like a heart failure here. Remember your boss? Hey, this is our top 10 MSDLG is heart failure. So does it affect our readmission? Is readmission admitting has an impact on our reimbursement because the bulk of the reimbursement is coming from this top 10 MSDLG. You can see in Vanderbilt, there are 798 cases of heart failure, okay? And their excess of readmission rate for heart failure is over 1, meaning that it's above the national rate. Whatever this is about 1, meaning that it is about the national rate, national readmission rate. For St. Thomas, they have 586 heart failure cases, and their readmission rate is below the national rate. So there's no penalty on it. Okay? That's how you interpret the number to your boss, to your manager. Okay? That's part of the job of a data scientist is able to interpret the number. Okay? I remember one time when a manager asked his subordinate and say, what is this 35%? Okay, 0.35. And then the answer is 0.35 is 0.35. That's not enough, right? You have to go further to it. Okay, and especially when a data scientist has to be able to compare to your peers. You're not only saying that you are over one, but how about you compare to Duke? How about you compare to Cleveland Clinic, because they are our peers. For St. Thomas, probably they want to compare to HCA. They want to compare to others, TriStar. See what I mean? So you pick your own peers to compare. Okay. Actually, this is not a good comparison because we are two different types of hospital. Yeah, but they are now neighbor. So I just put it out there. And I want to introduce you to another thing is here. And so your boss, your manager is getting excited by you because you did a good job and getting the data for him and then filter the data for him because this is our top 10 and do a correlation for him and also explain the readmission rate to him. Don't worry, boss, we are okay. Our reimbursement factor is 1, so we are not having any penalty. Okay, and then he got so excited and come to you again and say, hey, then how about our providers? Okay, so how is their reimbursement? Okay, hospital is reimbursed by MSDLG. How about your doctors? Okay. So of course you go back to your own internal, your own house data to check your professional data and the physician data. But on CMS site, they also provide us very good. And there is an online interactive data set that you can play. Okay, go there. Okay, I don't know whether you have the link to it. Are you able to go there? Okay, I want you to play with me. Okay, I want you to play with me. Are you with me now? Go to this website. Okay, first of all, it is very, very interesting. And this is the homework for tonight. Why CMS asked me to agree and not agree. Remember when you download the inpatient data? Are you asked this question? No. But when you come to this, they ask you this question. How come? Okay, that's the homework for tonight. Okay, and we'll tell you the answer next time. So you agree, of course, you agree everything. Otherwise, you don't have it. Yeah. And then you view data. Boom. See here. And the reasons why I did not ask you to download the data because this is huge. Okay, it will take hours and hours, probably bomb your laptop. So I don't ask you to download this data. You just play with it, interactive, on site. Okay, but I don't want to look at so many. So I want to restrict it, filter it out. On your right-hand side, you can filter out national provider identifier. Well, I don't know who they are. I want to look at just Tennessee. Or just Nashville. Okay, if you keep on like add a new filter, of course you can add whatever you like. I just show Tennessee. Okay, and at the end it will ask you. There is a filter for you to filter the state and the city. See here, city of provider, Nashville. Okay. Enter. Boom. It will give you only Nashville. Nashville, Tennessee. But bear in mind, there are other cities called Nashville in other states.
Yeah.
Right? Yeah. But there, I come across this Nashville in like Ohio. Yeah. So there are lots of Nashville elsewhere. But anyway, fortunately, we have the Tennessee here. I want you to look at this. HCPCS code. Tell me what it is.
DBT code.
Yeah. This is the Healthcare Common Procedures Coding System. Okay, HCPCS, they call it HCPCS, PCS, code for the specific medical service furnished by the provider. This is the pay schedule of provider, the doctors. It's not paid by MSDLG, it is paid by HCPCS, okay? Paid by this code, okay? And each of this code, if it is 99215, you got a pay scale. If it is a 7308, then X-ray, you get a pay scale. So there is a fee schedule attached to this, okay? It is not the same as hospital. Hospital is like, if it is Medicare, I'm talking about Medicare, because like Cigna or Blue Cross Blue Shield, it is all by contract, the network, the contract, right? But for CMS, it's like by this HCPCS, okay? Okay. And this HCPCS is related to your homework. Remember what your homework is? Why we have to click agree before we come to this page? Remember what that agree is? The CPT code. Yeah, because CPT code is not set up by CMS. Okay, so you have to agree to their agreement to use, and then the HCPCS is built on CPT code. It is more than that. CPT code, and then CMS put some flavor, put some lemon, put on some mint, okay, put on some sesame, and then build it HCPCS. But the foundation is CPT code. So that's why at the very beginning, before we come to this data page, you are asked that you have to agree abiding by all the rules and data governance by the CPT code, okay, because it's not by CMS. Okay, so, and this CPT code, there is like a drug indicator. Is this a drug? No, this is not drug, right? So it is N. Hey, this is it. This is the injection. So this is related to a drug. So if you go on, today, this one, I really like this. A vaccine for influenza for injection into muscle. So this is related to your flu shot. Okay, so, and you go to your clinic and your doctor gives you a flu shot, then he will charge CMS if you are a Medicare patient, and then they will send the bill to CMS and charge under 90662. Okay, and then CMS get it and then pay your doctors. Okay, so your physician, your clinic, your outpatient is quite different, very different from your inpatient setting. So if you want to know anything more about it, if you want to pick your own organization, if you want to pick your own physician, okay, your own primary care, then I think they are there. See, this is the physician name. This is their name. So type in your primary care doctor and see how many vaccines they make, okay, etc. And this is like, there's a dollar sign there too. The total payment. See here is the average Medicare payment amount. So you know how much your primary care physician billed Medicare for taking care of Medicare patients. So this is the payments too. So if you want to do some intellectual exercise, you can come to this page. And then once you have the filter, you can download the data. You can export. See here? You can export the data, okay? And you can API. I remember I saw somewhere there's an API function too. You can API the data as well. So, and this is a huge data. This is a huge data set. So don't think twice if you really want to download this because it is huge, okay? Yeah.
Does have anything in there that would apply like for any type of risk analysis, because that we can see if somebody had complication rates and how high the recidivism rates for all that, so it's for
Yes.
repayments and stuff
Yeah.
like that.
The CMS is risk adjusted. The payment could be risk adjusted. Yeah. For risk adjustment in the whole CMS system, there is like what we call the risk factors. And there's a whole series of, if you are interested in that, and we can do it in spring. Yeah. Lately, I kind of dig into the risk factor as well. Yeah. It is all public. You can go to the website to download it and do your own risk adjustment. Right? Yeah. You can do your risk adjustment. Okay. By age, by gender, and by the condition, what kind of diagnosis you have. Then they have an equation for the risk factor adjustment. All right. So this is like will be provided in the PowerPoint. I won't go over. When you click, you go to our website, and then this PowerPoint is available. If you click it, it is like all these like website. It is embedded with website. You go to the CDC, okay, and this is like know your data, okay, especially if you want to compare the benchmark. For example, this AHRQ. Why I introduce this? Because the next workshop is the clinical coding. Okay, if you want to learn clinical coding, what is MSDLG? How MSDLG comes out? Okay, it is a lot about coding. And then if you want to know about coding, how you convert the diagnosis code into some reasonable payment schedule, AHRQ, there's a lot of data there. And you can go there to download the crosswalk, to download the list. And this is a very good website as well, available. Yeah. I always come to this website to get some reference. Yeah. And this is my favorite, Restad, right, in Minnesota. Okay. In Minnesota, if you come across some CMS site, you don't know what that means, you go to this website because it is a dictionary to CMS data. If you have any CMS variable name or file that you don't understand what that means by outliers, whatever, okay, how they determine, come to this site. This site will tell you, okay, right? This site is very good. Yeah, this site is very good. You come to this site and it will tell you like the code dictionary here. You find all the code dictionary here in this site. Yeah. And QualityNet. QualityNet is another very good resource that you can go to explore. For example, for the readmission methodology, if you how they calculate readmission rate, okay? Then you come here, hospital inpatient, claim base, and there is a HRRP program there. See, readmission measures, okay? You go there, and also mortality, how they measure, okay? How they impose the penalty, how they calculate the penalty, the adjustment factor here. So there is a readmission measure here, okay? It will tell you all measure methodology, and they will explain the methodology that they use is the HGLM, okay? And that is how they calculate the readmission rate. So you get all different, see here, methodology. It will tell you how to get the readmission rate. And you can even send an email to them, which is at Yale, the core center at Yale, and ask for their SES programs. I just did, yeah. And I sent an email to them and they just send me the SES code. How the whole SES code is they use to calculate the readmission rate, which is very cool. Yeah, because by looking at the code, you know how they do the data cleaning. They know how some is excluded, some is included, that kind of thing. And then at the end, they did like a bootstrapping HGLM. The whole codes are there, so it's cool. Of course, it may not be your interest. You probably may be interested in more in the payer side. The United Healthcare, Cigna, Blue Cross Blue Shield, they all also have white paper, reports, etc. So there are lots of like resources here, and they are all, if you click, Okay, I used to work on data on NCDR. Okay. And so I come to this site a lot. So this is also, if you are working for the cardiologist or cardiac surgery, this is a good site for your reference. It really depends on what your role is. Yeah. And so there's a lot of, and this is the hospital ranking. Okay. And just recently they released the best hospital in the United States. I think they just released about a few. See the best hospital US News ranking, and then you can find which best hospital you would like to go. Sorry, I don't want to go. I mean, just like you want to see like what is the rating of the hospital, and so this is the website. Okay. So, but I don't want to go over each by each. You can go to our our meetup site, and you have the PowerPoint, and then each of these is embedded with link. Where's my mouse? Where's my mouse? Any questions?
Did you say we can get more?
Yes. You already did, right?
No, not yet.
Not yet, yeah, but we will. I thought we did. Okay.
I haven't got your selected.
Sorry. So don't worry about all those things. Once you open the PowerPoint, you check it, then it will pop up on this website. Yeah, all these different sources, government agency, CNS, and the all other like academia. Yeah. So, any questions? Any questions you would like to ask your neighbor? Yeah, and okay. If not, then make sure you know the name of your neighbor. If not now, just after. What's their name? Yeah, and make sure that you know one name before you leave here, so the next time you remember him or her, and that makes more fun, right? Thank you for coming, and we appreciate. We usually have a survey, right? We usually have a survey. Yeah, we have a survey on our meetup today site. Feel free to, after today, what do you want to learn, or what do you want to discuss, or what you want to share? If you come up with some good idea you want to share, I appreciate you come up with a file that you, for example, today's file, you say, hey, Christine, I saw this beautiful file, I want to show everybody, and no, we would like you to come up here to show everybody how to do it. And it is your meetup, and it is here that you your time, and we appreciate if you engage together and share. So, any questions? Should any email? For the next time, we have the workshop number 2, and the speaker and the instructor is very, very good. She's good. So she will talk about the clinical coding system. The clinical coding system for all these like ICD-9, ICD-10, diagnosis code, procedures code, MSDRG, and how to come up with like CC with MCC, all these outpatient, the head fix for the DMS. Yeah, I asked her. Thank you. Have a good night. Yeah. Enjoyed it. I know. I've been away from this for so long.
You ever use the physician?
Nice to meet you.
It's like, yeah, I wanted to actually do.